For example, the mutation of gene for mismatch repair related to non-polyposis colorectal cancer. For example, BRCA, the mutation of gene BRCA related to breast cancer, to ovarian cancer. BRCA is also related to pancreatic cancer, increase the risk of pancreatic cancer. We have patients with Coetzee syndrome who have an increased risk of pancreatic cancer. But all patients with 2 first-degree relatives have an increased risk. But unfortunately, all these patients represent only 10% of pancreatic cancer. So the number needed to screen remains low, and the cost of screening is high, because to survey this patient, we need 1 magnetic resonance every year. It's too much expensive, also for a rich healthcare system. So another target for surveillance is to survey the cyst. But the patients with pancreatic cyst are not at high risk, have moderate, low risk. The cystopancreas is another. We have several types of cysts, but the interesting cyst for the pancreatic cancer is IPMN, intraductal papillary musculus neoplasm. This neoplasia is a precursor of pancreatic cancer, but it's a precursor detectable with CT scan, with magnetic resonance. So we have 3 types of IPMN. The first type 1, is the main duct IPMN. This IPMN involves the main pancreatic duct. The second type is branch duct, involving the branch side of pancreas. And we have the third type is the combined, the mixed IPMN. So the risk of malignancy is high when main duct is involved. Unfortunately, the prevalence of this type of tumor is low. More frequent is branch duct, but branch duct is malignancy only in 1–5% of cases. So this pathology provides us for the first time a model to progression from normal epithelium to low-grade dysplasia, moderate dysplasia, high-grade dysplasia, invasive cancer. If you try to cure the patient in this moment, yes, the patient is curable, but the sample is too much. I'm not sure that all patients arrive to invasive cancer. When I try to cure the patient at this point, it's too late, it's incurable. So the good point is this: in situ cancer. In this point, the surgery is curable. So my target, when I see a cyst, is to operate the cyst with in situ carcinoma. The patient don't need chemotherapy after surgery, if my surgery is in this moment. Okay, now the first question is, how many time required the epithelium to pass from low-grade dysplasia to high-grade dysplasia? 1 year, 2 years, 10 years? This is the answer. It's a mathematical model. It's a long time, 20 years, from low-grade dysplasia to high-grade dysplasia. So we need to survey the patient for 20 years. Once again, too expensive for the healthcare system. So this is the big problem of pancreatic surgeon when to see a pancreatic cyst. But the greatest risk is the surgery. Be careful. This is a famous speech in Europe because the freedom of Europe was born in this beach. This is the Omar beach, and this is that picture of landing of Allied troop against the Nazi occupation. This is a famous beach for the mortality rate. In D-Day, the mortality rate in Omar Beach is this. This is the same mortality, perioperative mortality, for pancreatic duodenectomy for cyst. So when you candidate a patient to pancreatic surgery, is near to mortality of troop landing in a Second World War, in a beach of a Second World War. So this is very important to remember, because be careful when candidating a patient to pancreatic duodenectomy. So we have some instruments to select our patient. This is the guideline of Fukuoka. We have the high-risk stigma. Patients with high-risk stigma go to surgery because this patient has a high risk of in situ carcinoma, obstructive jaundice, main pancreatic duct over 10 mm, enhancing mural nodule inside the chest at the symptom malignancy. Be careful to the jaundice. Is specific, this is a meta-analysis of our group. This is highly specific, but jaundice have a low sensitivity. In other words, the presence of jaundice means pancreatic cancer, but the absence did not exclude pancreatic cancer. Mural nodule is highly related to malignant tumor, but only enhancing mural nodule when after CT scan or after magnetic resonance MRI, you can see the contrast inside the cyst. Okay? We have a second type of patient with no high-risk stigma, but worrisome features. There are some different worrisome features. Pancreatitis, thickened enhancing wall, cyst size over 15 mm, MPD dilatation inferior to 10 mm, but superior to 5 mm. So the best predictor of malignancy are thickened enhancing wall and MPD dilatation. But the problem is the same. High specificity, low sensitivity. In my experience, I do not candidate this patient to surgery. I perform always AUS, ultrasonography and endoscopic ultrasonography. You have a probe in the endoscope, and the probe is a radial probe. The image of ultrasonography is this. And you can explore head of pancreas from duodenum and body and head of pancreas from body tail, from stomach. This is the image, tumor, the portal vein. This is the needle for biopsy. You can obtain a histological diagnosis with the AUS. So, when you obtain a positive histology, it's a high-risk stigma. The patient go to surgery. But remember, negative histology did not reduce the risk of cancer. So, once again, we have a high specificity and a low sensitivity. But the majority of patients is in this class, low risk, no high risk stigma, no worrisome feature. So this is the problem, because the scale recommended a CT scan, MRI, or ALS every 6 months, 6 months. This is a very expensive. And also for a public healthcare system as in Europe. Europe we have all states have a public healthcare system, except the Dutch healthcare system. So we try to solve this problem because the follow-up is designed by the risk of GIST, but it's not correct. The scale of follow-up, the timing of follow-up must be calibrated on the time for the cyst to develop high-risk stigmata and what is of vision. So we try an unusual approach. Our knowledge is based on this type of analysis. Kaplan-Meier curve. Kaplan-Meier curve implies constant risk over the time. But this is not reality. This is an approximation of reality. The reality is this. The risk will change over the time. It's too late for us. No. Your mobile. The duration of your mobile is based on this curve, not on this curve. The duration of your car is based on this curve, not on this curve. So, we calculate the failure time, the time to develop a failure, but not for mobile, for EPNM. The failure for EPNM is occurrence of what is a failure or RP16. We use a large international code, very large. We trained the model in Europe and in the USA, and we do a journey as a famous traveler in Europe, Marco Polo. In the medieval age, do a long journey to China. And we go in Singapore and Seoul to validate our model. And we obtain the same result in Western and Eastern coast. You can see the two similar for red and blue. So, we obtain a simple model, this. Increasing age, increasing the risk of change. So, the time of observation needs to be time. So, 24 months between 75 and 80 age, for example, and when increase the diameter, was reduced the time to develop high-risk stigmata and what is okay. So, in this, if you see this picture, you do try a patient with a follow-up every 12 months, but every 5 years. So this is the schedule correct to observe the patient. Now, patient point of view. The patient experiences a financial toxicity because this is the price of a public system, but this is the price, the price of private hospital to do a magnetic resonance. Our patients are protected because are in a public healthcare system, but our patient experiences financial toxicity, discomfort related to the need to pay the exam. So, return to pancreatic cancer now. Come back to pancreatic cancer. Because in the last 10 minutes I speak about the precursor of pancreatic cancer. But pancreatic cancer occur also without precursor. For symptoms. For symptoms related to pancreatic cancer, back pain is a typical pain, gastric and back pain is typical symptom of pancreatic cancer. Worsening of diabetes. Be careful with the patient with worsening diabetes or with early onset diabetes. Be careful to patient with theater rare, fatty, fatty and yellow stool. Be careful to notice. The preparatory staging is similar to other tumor, PNM system. And the preparatory staging in pancreatic cancer is based on CT scan and classification of DNA. But we number the lymph node using Japanese classification. When I was resident, my role is recognize all stations. For example, station 9, station 8, hepatic artery, station 12, hepatic ileum, station 13 and 17, pancreatic bed. I remember from my residency the number of lymph nodes. This is very important. The CT scan is fundamental to technical location, to see the indirect sign that this is a related virtue. No? So, CT scan is important to see the distal metastasis in the liver, in the lung, in the peritoneum, in the brain. So, but the most important point is liver, the first site of metastasis. But which is the risk in the CT scan? The risk is the tower, the Babel tower, it's a famous legend in Europe country. They could confund the language, and surgeons speak very frequently different language. This is another reality. I resect, the resectable PBSC is the one I can resect. It's a typical sentence of surgery. This sentence is based on technical background. This sentence is based on when you have an idea of curing a systemic disease with the hand. This sentence is based on an acknowledgement of a worldwide accepted classification. But why patient with resectable PDSC? Now you can eat some indigestible, the pancreas anatomy. So the local resectability of pancreas is in this area. Engagement of superior mesenteric vein, engagement of portal vein, engagement of artery, engagement of arterial, superior mesenteric artery, and hepatic artery. So in this area, you play the resectability, the game of resectability of pancreatic cancer. So this is the classification. No contact with vessel, resectable. Contact, small contact with vessel, borderline resectable. Large contact with vessel, local advanced. Metastasis, no resectable. So, full category. But which is the difference between resectable and borderline resectable? The difference is here. The probability to obtain a radical resection in this tumor is low. The probability of microscopic residual is high. So the dimension is displayed in this position. The surgeon needs to learn the CT scan. It's not the responsibility only the radiologist. Surgeon must to see the CT scan. This is a study. This is a radiologist and this is a surgeon. Normally. But really, we we have a disagreement about the receptability. Okay? And this is a problem because the receptability different from different centers. And we have another problem. We have another type of borderline lesion. Patients who have high value of macroneoplastic marker, CA. When you have a CA 11 more for 500 or 2000 international units per millimeter, the risk of metastatic spread is very high. Micrometastatic spread. You don't see the metastasis, but the metastases are in the liver, really. So, this is the history of two twins. One twin received dialysis at T0 time. Was operated. This patient had micrometastatic disease, but the surgeon don't see micrometastatic disease. The patient perceived this time as survival time. This is the second twin. Did not receive dialysis until to detect, to discover the hepatic metastasis and the actual hepatic metastasis. This patient and the same survival. This is a lead time bias. It's an anticipated diagnosis. It's not cure of cancer. So this patient go to neoadjuvant chemotherapy when the risk of liver metastasis is high, of micrometastasis. The patient go to neoadjuvant chemotherapy. So this is the summary. Resectable disease surgery, borderline resectable disease, neoadjuvant chemotherapy, local advanced neoadjuvant chemotherapy, and metastatic disease only chemotherapy. So, finally, two technical aspects. If the tumor is located in the end of pancreas, this is a video. No problem. No problem. So, we will go. Okay. This is the step of pancreatic duodenectomy in our hospital. We use a midline incision, but our sample use the subcostal incision. I prefer the midline incision, but this is not a big difference. So, the second step is the opening of gastroesophageal ligament and lowering the right colon flexor. As first step, frequently I do complete the rotation of the small intestine to control better the mesenteric artery. So the second step is Cocker maneuver. It's the rotation of the pancreas, and we do the Cocker maneuver until to see the left renal vein. So this is the limit of Cocker maneuver. The third step is the uncinate approach. I isolate the uncinate process of the pancreas and I prepare the superior mesenteric vein. At the end of the uncinate approach, we go to hepatoduodenal ligament and we identify artery, biliary tree, and portal vein. We cut gastroduodenal artery
ขนอพาเนี่ยเขาเปิดกระเพาะ
from this point,
รอกระเพาะมันบอก
and we cut biliary tree. We cut duodenum or
ก็ต้องเรียกว่าต่อกัน
gastric or stomach depending on the technique. We have two techniques. Traverso lombar technique.
บริมีเคสหนองช่องเคส
Is it different?
ตัวมือเคสหนึ่ง
We control the neck of the pancreas, separating the neck of the pancreas from portal vein. And this is the image of before the resection of pancreas. We control all vessels. In this case, we have a replaced hepatic artery from mesenteric vein, mesenteric artery. So we cut the jejunum, the first leg of jejunum, and we cut the pancreas. We use the knife. We don't use electric knife because this is very important for the pathologist. We perform always evaluation of margin inside. So it's very important for the pathologist to have good margin, evaluable margin. The last step is to dissection of small vessel between portal vein and artery and mesenteric artery. So the resection is finished. This is the image from my point of view at the end of the resection. Portal vein, splenic artery, pancreatic rectum, hepatic artery. Now the reconstruction. This is the anastomosis. I prefer anastomosis. This is jejunostomy. We do two layers, one external layer and one internal layer for each side. This is the typical anastomosis, but we modify this anastomosis. This is our application. Using our technique, the Logar technique, simplify this technique. I use suture for stitch and other suture. We obtain a good result, reducing the mortality. This is some image of jejunostomy. We use an internal tutor, internal drainage. But in some cases we use also an external drainage to reduce the risk of pancreatic fistula. This is some image, some picture about the external drainage. The French surgeon used this technique. I don't like this technique. It's pancreatico-gastrostomy. The anastomosis was between pancreas and stomach, not between pancreas and the It's a very complex technique. It required required the opening from anterior and posterior wall of the stomach. I don't like this technique. After the pancreatic anastomosis, we perform the hepatobiliary anastomosis. I use the two single layer. I prefer to perform anastomosis with a continuous suture. But when the biliary is small, I use single stitch. But I prefer continuous suture for this anastomosis. And at the end of the procedure, gastro-jejunum anastomosis. So, about robotic surgery, in this moment, robotic surgery is the topic of the moment. It's a hot topic. Yesterday, I discussed with Ilaria and about this question. Robot is form. Is fear of missing out for an example? Or is real? Is the miracle cure of pancreatic cancer? So, my answer is that it's form. This is a recent paper published in HPV, in which we demonstrate that from cost effectiveness point of view, robotic surgery is as because it's too expensive and do not ameliorate the survival of patients with pancreatic cancer. This is the only procedure cost effectiveness. The rest of the procedures are with increased cost or not effectiveness as laboratory. So this is the reality. Finally, the result depends not only on the tumor, not only on the surgeon, but on the medical team. We have a core team dedicated to pancreatic xenoplasm, radiologists, pancreatic surgeon, oncologists, gastroenterologists, and those. And we have a vision network. Finally, this is some picture about our multidisciplinary team. We discuss all cases. And to win, it's not important one champion. To win is important the team. So, thank you. I leave the speech to the floor to
Questions at the end or?
But at the end.
แสดงว่าเขาพาแพนเค้กเนี่ยเขาต่อกับกระเพาะเลยว่ะต่อกับตัวเจดโนว่ะ
บ้านเราใส่เป็นโฟม
กันเท่านั้น
บ้านเราอยากจะใส่เป็นโฟม
Okay. My speech today I'm talking about multiple neuroendocrine coagulation. I don't know how many of you knows about the innervation of the lung. You know that the lung is innervated? Probably no. So this is something that even them they don't know about this. So the interesting part that I'm going to fly over today in part 1 and part 2. Part 1 is the etiology, where they come from, and then ask 3 questions. There is an impact of this multiple neuroendocrine in low-grade neuroendocrine tumors. There is an impact in a concomitant adenocarcinoma. This lung carcinoma is the most common tumor of lung. Number 1 is worldwide tumors, and adenocarcinoma is the most frequent in this number 1 lung cancer. And there is an impact in patients enlisted for lung transplant. Part 2, if we have time, we're going to talk about a little bit of the surgical procedure and the continued message. So, the 3 questions, the etiology and 3 questions. Usually, the neuroendocrine tumors are part of the big picture of the lung cancer. But it's not a big one. As you can see here, they stand off on it's running too fast. So this is the imagine this is all the lung cancers. Usually our carcinoids and carcinoids stands right one way. And if you see the neuroendocrine lung cancers, which comprehend the carcinoids, large neuroendocrine cancer, and small cell lung cancer, are in a group. It's like a little slice of this cake. And what we are talking today is of the presence of small neuroendocrine particles along with typical carcinoids, more likely. But typical is the lesser aggressive form to typical carcinoid are the more aggressive one compared to the others. So, so this quote came from today. This gentleman who say, certainly more frequent as reports literature lead to assume that these tumors secondly are not so rare. And he is convinced that more attention is paid to them in the future than is number of increase rapidly. This gentleman was over in the beginning of the last century, in 1907. So, in this contest, with the low-grade neuroendocrine tumors, we have several of those lesions. This is about neuroendocrine, so-called treatment, the tumorless, secret carcinoids, and neuroendocrine cells. There is a huge group, and it's quite not well understood in the literature. This is a pictorial in one of our papers published recently, where we have nephropathy, usually arises in the center, the bronchi, but we have our river, but it can also grow beneath the mucosa and increase the striking around all the mucosa of the bronchi, or even a tumor can really go down into there's an iceberg into the lung brain. So in the background history, they were like they started to study the lung carcinoid, as I say, with a gentleman before this Humber in 1937, started to study and define as adenocarcinoma, adenoma. And the word at that time were considered as non-malignant, benign. Okay, there's no metastasis. We don't think it's going to happen, and so they consider it as benign. And slowly in the years, there is in 1959, it's like a wheel of time. In 1992, Hawaii started finally to define the other, this so-called idiopathic diffuse hyperplasia. And it was done in 1992, and this gentleman from Mexican American started to define this. And later on, this gentleman created this in the split in a typical large cell and small cell in 1998. So this, and he started also to define it as a pre-invasive issue at that time, and also WHO, and in 2004 remained in 2024 this definition. So Mr. Freitas say, well, I have to say, typical carcinoma large cell and the combined cell neuroendocrine those are dead guys, more likely in the last two, C, and the so-called non-small cell carcinomas. So it's kind of going to the really aggressive part. But the cell hyperplasia tumor, so there are some debatable discussions on it. As we know about it, we're discussing, and we started to really start to think about it. So we published recently in 2022 a paper on this hyperplasia tumor that's is a misconception, and we stated that yes, these are rare, unrecognized, but if you thoroughly investigate in the specimen, it's going up to 17.5, 28% on a single specimen. So that means if the pathologist is paying attention on this, it can help. It can help really a lot, considering in the follow-up and to understand the disease mindset. So where is coming from this issue, this problem? So as usually in the lung cancer, we have genetic, we have molecular, but also we have environmental factors such as production of pollution from the car. This is very interesting poster that published in the northern part of Europe, and it also can be also associated with chronic lung disease, with the notch pathway inhibition, and so also keep the transcription of different molecules that play a central role in this program. And going back to what I said, the lung is innervated, yes. Lungs have nerves. Has nerves from vital and conduction, and has chemoreceptor. They can go into reception. Reception is those little teeny tiny part of this subecosa that drives all the information to the through the vagus nerve and to the nodose ganglion, tubular ganglion, and this is very important. It's not nociceptive. It does not give pain to the patient. You don't have to feel pain. But what you feel is coughing. Right now you're coughing, and this is an impulse driven by this chemoreceptor, this receptor that is under the mucosa. And we know for sure, sorry, that I know it's running too fast. We know for sure from the text, that the vagus nerve has different involvement in different other parts of the body. So it's really important to know that also the lung has this particular mechanism. And the other thing is, this is, of course, there is similar things that showing you in a different way. But what's important is, you see, when is hypoxia placed around, there is pollution, and you breathe in and out, you have difficulty to breathe. It's not because the blood arriving to your brain and you start to breathe in and out. It's already given by those receptors. Those receptors is connected to the capillaries and release this information as well. Not only, and it also has different other parts, the hypoxia, because systemic vasodilation, sympathetic activation is here. It's increasing the heart rate, increasing the cardiac output, increase the blood pressure, cardiac velocity. So everything is connected by itself with the vital system. And as well, there's also hypoxia fuels the cancer. And lung cancer, this is all general, all different, right? Switch to anaerobic metabolism, genomic instability, angiogenesis, inflammation and suppression, resistant to radiotherapy, chemotherapy, and immunotherapy. Basically, the cancer by itself protects himself against the other hypoxic cancer. And this is also, it makes a sort of web around and create a sort of protection against the virus. So let's go to the three questions. There is an impact of the membrane, this multifocal neuroendocrine in a concomitant low-grade neuroendocrine tumors. So there was this very interesting published paper I was discussing with my colleagues in Mayo Clinic, and the colleagues of Marie-Christine and she was pulling together 28 patients. At the time in 2007, where I was a resident like you, and I was just starting to think about it, and she published like 2 years later, so there was a serendipity here. And she said, and she found that basically, I don't know why it's something. It's the Wi-Fi system stuff. Yeah. So yeah, it's okay. No, that's not the one I was showing. So she was saying, okay. So she said in our series, the largest population multiple carcinoma tumors. So multiple carcinomas in tumors say that reveals multiple commonly patients with presenting metastatic disease. Therefore, the mutation is rare, around 5%. So also those patients have persistent disease. And we started in 2004 to start the symptom of multicentric tumors. And we slowly getting through the years, 2009, 2014, we increased the study on this report to analyze in the node. We did not expect something apart that by putting on a bigger follow-up, because in this case you cannot, and the oncologist knows very well, and also Professor Rich knows that everything is balanced with the follow-up of the patients. You need to follow and see. For these kind of patients, as for IgM, it's not 5 years, 10 years, it's long life for the rest of his life, basically. But key question, and I have to thank you, that basically you need to understand when you have to follow up. So sitting in people, very expert people, and talk about, okay, we need to do like 2 years, 3 years, 5 years, that is maybe cost starting with thinking about AI, he is going to talk about AI more.
Oh,
And also start to think about mathematical studies to know when it's better, because you can really readjust the cost and you can really find the perfect follow-up for those patients. So, given this, we started to, I was studying the way around. I was studying with mathematical model, I was studying with the UNC things, and I started to really think that this is maybe the real way to do it. But anyway, so we took our 73 patients with NET. So we say, what about taking from those cancers this particular population, study it in a certain way with a pathologist, and see if these patients have something wrong or not, and compare. So we ended up to not big numbers, but 58 and 50, and we didn't have a difference between typical and typical carcinoma with multi-center forms. But what we see more lymph involvement in patients with atypical, which it makes sense. But at the same time, we have not only the single tumor, we have also and here you can see it specifically, having multifocal disease is something that should be more when we are studying. As well as putting a Venn diagram on those and then maybe a multifocal expression, how they occurs, because they were in different terms, hyperplasia, carcinoma. We see basically more likely when we have months of hyperplasia and tumor